So I would like now to invite Dr. Sharifah Khairul Atika binti Said Kamarudin. So she's a chemical pathologist and she's head of the unit of chemical pathology in Sungai Buloh Hospital. She also has served as quality manager and has been involved in various committees in quality assurance and accreditation and training. So without further ado, I would like to invite Dr. Atika to come to start her presentation.
Assalamualaikum and good afternoon everyone. Thank you MSCB to actually call us up for this webinar. Me and Dr. Firdaus, my colleague, is very fortunate. Actually, when we are given this task to talk about the importance of supporting tests in management of COVID-19 patient, I was thinking because we are not doing anything extra, unlike my microbiology colleague. But actually, this presentation, I want to run through the journey that how we have handled this particular pandemic. Okay, so. Okay, so in the beginning of the year of 2020, we had the first case ever come to Malaysia. So I think my colleague has already, Dr. Tuan Suhaila has already shared the management, the planning part in actually catering for this particular COVID-19. But here at home in Sungai Buloh, we are having our nightmare when the total IT system really shut down on us, for quite a number of weeks actually. So as you can see here in the newspaper, it's also come out, and I hope you can see the upper part is the test that we can accept during our downtime. So meaning to say after 5, there's going to be limited of tests in all units, be it in my unit, the biochemistry, the hematology, and also the microbiology. But from 8 to 5, since we have the full strength of staff, we try to accommodate as much as we can for our in-house samples. So here it is, the amount of manual work that we have to undergone during this downtime. So my staff here tracking the sample, the result to the request form. And during this time also, I had to deploy my ABG. I have 2 units initially. So 1 unit I deploy outside my lab. So the doctors going to have to do it on their own. So this is the vendor teaching them all the way. Very thankful to them. They come as early as 5 a.m. to actually catering for the houseman rush early by early on. So this is the peak, because we have quite a long time for the downtime. It runs very long. That's why my ABG has already come out outside of the lab. Okay. So I sharing with you the first few interim guidelines that come out, the MOH from January onwards, and also the initial guideline actually only mention about the respiratory sample, how to be sent, the sample type until it's arrived to the lab. So what about the other testing? So when our first case arrived in Sungai Buloh, the initial test requested limited only to FBC, the full blood count, renal profile, and also CRP. Because during that time we are during our downtime, so we cannot deploy our staff to the procedure room in the ID ward. So the sample has to come down to the lab. So all tests except for the ABG is done in the main lab. So we don't have the assigned area, meaning to say everything is done in the routine practice, but we somehow assign our lab to cater for the COVID sample. For the initial, I think 1 to 2 weeks, we try to batch according to time, send every 3 hours. Especially we try to catch the sample in line with the molecular testing. But as the patient getting ill, one of the case, so the request started to become more. They started to request the liver function, the ferritin, and also the high sensitive throat eye. So from very beginning, actually the test that they are requested is actually quite a lot. If we are talking about just simple tests like the ABG and also some renal profile, the BUS, it can be done in POCT site. But once the patient, the testing is quite more, then the POCT site cannot cope anymore. But for this COVID-19, the sample already arrived to the lab. So we don't batch testing. So this is the flow that we did, so that our the technician knows what to do lah. So the PPE, and then how to actually process the sample. When the sample arrive, we wipe, and then we get the sample out, and then use the closed bucket to centrifuge, and also up to sending the sample to the analyzer for testing. So after that, again, after finish the analysis, then we also outline the procedure, especially to the staff, in actually how to handle the contaminant and also the waste disposal. Okay, so this is the flow. This one I need to outline. Remember, we are still in the month of January. So the star here is actually our BSC, the Biosafety Cabinet. So it is located in the blood bank. So this is my biochemistry lab. This is the hematology lab. This is our receiving counter. So when the sample arrive, it's going to be here. Then I going to the PPK, the MRT going to bring the sample here. Here come and centrifuge and prep the sample in the BSC. Then again come out here for biochemistry and also hematology lab. Okay. This is the section for outsource, meaning to say the sample that we send out. So from receiving counter to the outsource, again using the same door and out of the lab. Okay, and from receiving counter, our microbe testing also using the same door right to their microbe lab. So this is to show that as a manager, I would say you have to really plan and look back in your procedure how to best fit, because you know it's going to be a bottleneck here. There's going to be a highly traffic over here in January. That's the thing that happens. Okay, so actually in biochemistry lab, the integrated lab, I also having some issues. So actually we just got our tender award. So it's going to be a change from of platform from Able Architect to Siemens Italica. So the reagent last that we procure for architect is the last year, the 2019 period during budgeting, and we are running that on architect before the Italica comes in. So we need to plan ahead. Okay, we need to plan where to put bench to come out, which area to assign the new analyzer. So during this time, during the downtime, we had to ask for help from our colleague from ESTA, the hospital Klang, to cater for our external sample, meaning from other hospital and also klinik kesihatan to send to hospital Klang lah during our downtime. So I have to rush through the training on the new platform on Italica, and during this time we have the mixture between COVID and also non-COVID samples lah, because we are still having our clinics and also wards sending both. So the sample for biochemistry and hematology for our blood sample will be also sent in box. So the counter has an important role in assigning to which MLT it should goes to. So comes the month of February. So this is where our first cases comes. So on a national level, the lab has to get prepared, and then we reviewed again our guidelines. So the case definition back then in February is this, and also we, as you can see, initially we classify the patient into mild to moderate and then severe group, the clinical side. So mainly the supporting investigation that was mentioned in the initial guideline is just FBC, the full blood count, CRP, LFT, renal profile coagulation, and blood culture. Okay, ABG if required. So back then, looking back in hospital Sungai Buloh cases, we got a spike in the PUI cases, the suspect COVID. So for Sungai Buloh, it's just going to be either COVID related or non-COVID related. If non-COVID related, the blood should be sampled just as usual, can shoot through the pneumatic tube. But the moment it's COVID related, whether it is a COVID confirmed or still under investigation, pending investigation, all will be sent in box. Okay. So this is the flow chart that we prepared for our clinical colleagues, so that the ward people have an idea how to go about. Because we have so many practice, so we outline pictograph for them, and we mention how to really send the sample to the lab lah. And then on top of that, we the biochemistry unit officially tell our client, the internal and also external client, that we are changing from one platform to the other, to the new platform in lieu of the new tender. Okay, so there's so many things happen in January and also February. So this is the one renovation, my compressor and also the water system room. This is what the plan, and we have this is the where they put the wiring, networking cable. We got boxes everywhere in the lab, and this is my staff doing the training. So we have both analyzer running concurrently. So here we have the new analyzer, our Italica, and on top of that, the sample is still run on Abbott Architect platform. Okay, so when March comes, the cases spike. Okay, and so that's what happened in the biochemistry and also hematology lab lah. So our numbers for the confirmed and also the PUI cases jumps, and then we start our lockdown. Actually, I'm showing this as a reminder that this is the when our cuti beku. Okay, Hospital Sungai Buloh is a designated hospital for COVID-19. And then we review back our PPE practice. We refer to this particular guide on the rational use of PPE. Okay, but then there is more evidence on COVID-19 on the sample type and the positivity rate. So we can see it's not as much for blood. So it is important for us to actually review whatever we have and review our practice. So this is the clinical management of confirmed case, where it is further defined and the clinical stage is further divided into 1 to 5.
Right click to change laser window.
Right click. Okay, so we have 5 clinical stages. This is the when it is updated in the 24th March. Okay, for biochemistry tests, I run for all in-house tests, but there are some tests that I suspend. Meaning to say, I stopped during this time where the HbA1c is no longer offered. Oh, okay, and then so there is no HbA1c done at all for our COVID and also non-COVID. This is pre-agreed with the clinician, so that I can deploy my staff to the other testing. So the section I totally close. And then for batch testing, I have the weekly hormones and also tumor marker. So for COVID testing, I do not keep the sample. So if it is request, it's going to be rejected and asked to be only be done during the time of batching testing. I do not offer the serum and urine osmolality. This is pre-agreed with the clinician whether the kind of test that can be done for COVID patient. 24 hours urine testing also is not done for them. So if they really need, then I ask them to send for the random urine for UPCI, not the 24 hours. And in March, I also started the procalcitonin for in-house sample. Okay, and since I do not run every single test available, so I do outsource some of the COVID sample. For example, I have sent a few sample for digoxin to Hospital Selayang, and also urine myoglobin for one case to IMR. But before I send, I have to call up and inform the respective unit. I didn't send my COVID sample as easily and without them knowing lah, so that they can also take precaution in the sample handling. So during this time also will be no more manual dilution. So it just preset to whatever the manufacturer said. During this time, it's already Etilica is already on board. And since I'm introducing new tests, I also plan for the EQA for procalcitonin. It is not covered in the previous sebut harga in department level. There were questions asked before whether I run the ferritin. It is run daily, even prior to COVID, because I am catering quite a number of severe dengue cases. Okay, and ABG, since it was outside of the lab, and my second unit I already deployed to the ID ward, meaning to say the test is done in the ward itself lah. But this require training, especially to the new handlers. Okay. So for hematology test.
Okay, hi, I'm Dr. Firdaus, hematologist Sungai Buloh. Okay, I will continue with hematology test. Okay, for hematology, actually we receive full blood count, the most basic test. It's around 250 tests per day. We have one dedicated analyzer to run COVID sample. And for pediatric cases, we use elevated bottom tube so that it can have direct piercing. The staff no need to open the cap, okay, to analyze the sample. And slide review was not performed because we want to limit the FBP. To make sure the result that we release is accurate, so we did strict delta check. So any sample that failed delta check, we suggest to repeat. And because of slide review was not performed, so we actually emphasize on analyzer flagging and histogram, especially for platelet clumping. Okay, so any cases that actually suggestive for platelet clumping, we suggest to send FBC in sodium citrate. Okay, for coagulation test, PTAPT, at the beginning actually we didn't receive any, but once the patient is getting ill, so we started to receive PTAPT. Compared to FBC, the problem in PTAPT because the waste management because we use ACL top, the waste management is actually open system. So we need to manually discard the waste for both solution and also cuvette. Discard manually as per protocol, and usually we discard once a day in the morning lah, at the end of before we start new shift. Okay, for FBP, we only accept urgent cases, example, especially hemolysis and acute leukemia. And all the requests was screened by MOs. And so far, no hemolysis reported. We done manually, we did the FBP manually in the BSc. So after the smearing and staining finish, we wipe the mounted slide with 70% alcohol before we read the slide at the microscope. And we discard the sample immediately after we release the report. Okay, from our risk assessment, actually we prefer manual procedure because our analyzer actually use fan to dry up the wet slide. So I think the blowing fan of the wet blood smeared will increase the risk of virus transmission. So I think better we to be safer to do it manually in the BSc. Okay, for GCSPD, we received the request for GCSPD at the beginning of the pandemic when patient received hydrochloroquine as part of the treatment. We did it manually in the BSc. We placed the filter paper in biohazard plastic after finish the procedure and wipe with 70% alcohol. And then we read under UV lamp outside the BSc. And we discard the specimen immediately. Actually, we did have trial of POCT because I think POCT is safer because 100% we can do it in the BSc. However, it shows inconsistent results, so we revert back to the manual. But later on, we didn't receive any request for the CPD as the patient no more put on hydrochloroquine because of the side effect. Okay, D-dimer. It was done for critical cases to rule out cytokine-related syndrome, and actually the request rise about 10 times than usual. As we know, in hematology, D-dimer is one of the expensive tests. So because of the budget issue and also the shipping problem, so after discussion with the ID specialist and after they actually study the trend, so they request, because before that actually they requested daily for the critical cases. So after discussion, actually the request dropped to twice a week. And fibrinogen, it done together with D-dimer, but fibrinogen is okay because we use giraffe method, so the cost is not much. Okay, for the CD4, CD8, after discussion with other specialists, it is not indicated for COVID patient. So if the COVID patient with HIV, they will withhold the CD4, CD8 until the COVID status is negative. Okay, I will touch a bit about the blood bank. It requested for PUI and COVID-19 positive or will be cross-match. All requests will be cross-match, and the cross-match blood was kept for 48 hours, and the leftover sample will be discarded, and the baby's blood will proceed with ABO grouping only, and emergency O blood was available in OT and ED. Okay. So I think Dr. Atika will continue about the issues that happen in the lab.
So during this time we encounter more and more problems lah, and especially in sample that was unmanaged. Unmanaged sample refers to the incomplete electronic transaction in the hospital system. So when the sample arrived to the lab, it cannot be registered or analysed. So this caused delayed TAT and repeated callings to the ward to actually manage the sample electronically. As you can see, this is the pictures shows the barcode that having the problem of these issues. That's quite a lot. And on top of that, the next to slide the boxes that arrive to the lab. So just imagine for one box, you can have multiple patients. So to call each and every box is quite taxing for us then. So the issues come because of the new staff actually in the clinical side. Okay, and then again we have the issue on inventory of reagent and consumables in maintaining the two platforms. And when once we are declared as COVID hospital, the samples are deployed. So we have abrupt changes in the workload internally, and then we are not familiar with the new platform requirement, how frequent, how much it's going to consume. So it is a learning curve for us, and also we are undergone the evaluation for the Etelica. So this is the outline of the evaluation protocol that we are using. And then we also have earlier on the sudden influx of new staff. So we need to retrain, we need to remind and how to communicate. Okay, and then we have to review our current sebut harga and also tender whether some need extension or not. We have to submit it early to get approval from MOF. Otherwise, once the system in the e-perolehan stock, we cannot buy anymore. Okay, and then during this time also I remove my one of my old analyzer, and the Ethelica goes live during this period of time. So once we are declared as a COVID center, we are deploying our external sample again from the smaller hospital and also the klinik kesihatan to the other hospital. So for example, the hematology test is done by, is covered by Hospital Klang, Ashtar. And for my testing is going to be at various places, mainly by Ashtar and also Hospital Selayang and also Hospital Ampang. So big thanks to them for covering us up during our difficult times. Okay, so again we revise our procedure again and again, because we notice now, because there are so many new clinical staff, they may have they did the microbiology sample and also the blood sample sent together. So when the sample for arrived at the microbiology lab, the biochemical and also hematological test is delayed. Okay, so we have to review our process to ensure our best that the sample won't get lost along the way. So again, frequent revision throughout the past few months. So this is where we try to assign the staff to keep the distancing, and this is an example on the ABG training. We show the doctors how to do it. Okay, at least I have some training materials, and that's my team down there. Okay, and comes the months of April. Okay, this is when we start to receive our contract workers and also help from the other institute, and the numbers spike. So during this 2 months, the April and May, we have to start divide the whole jabatan into two. The team A and team B, we come to work for alternate days. So just in case any team got positive sample and got to be quarantined, so I have half of the lab strength to really pull it off lah. So for 2 months actually. Okay, again we review back our PPE requirement based on this particular guidelines lah. So we review whether the need of N95 for them or the just medical mask and all. So we did do the revision quite frequently based on the current evidence. So then later MOH come up with their with our own PPE. Yeah. So the lab, this is the example, but mainly this is for the molecular testing. Okay. So again, we anticipate there will be global shipment delay. So we have to do the vigilant stock check to ensure our reagent, consumable, QCs, everything is in place. And by this time, my CRP request actually double, and I have to ask for certain routine testing being stopped. For example, thalassemia and hemodialysis, because these patients still arrive in Sungai Buloh. And then the request for PT and D-dimer also increased during this time. So this slide to show that by BSc, I already moved to closer to the campus and hematology lab. So by me, our hospital Sungai Buloh inpatient actually already comes down. Yeah. So again, what happens in my lab, still we are continuing our renovation and relocation of the lab. The counter get renovated. We remove the second analyzer, the old one, to give space to the new one. And also the outsource the sample to send out. Also the new section we have to relocate to giving space to the ongoing renovation. So again, the outsource from the counter has been renovated. So the outsource next to the counter move all the way up. Okay. So we have so many things going on. For these two letters come out actually to tell you about the counter renovation and also the electrical part that has been done. So actually this electrical part this pathology, the event happens in pathology, but impacting 3 level up to the ICU, OT, and many things, many level. Okay, so we have to inform them beforehand. So Alhamdulillah, no issues during that day. Okay, so comes June, actually the numbers are staggering around 300 to 400. The PUI cases start to come down, and I think the next one is quite a good journal to actually have a read, to know, to have a glimpse on how the other lab is practicing in COVID outbreak. So this is quite good survey being done by IFCC task force. So I think I advise everybody to have a look and see what this is all about. So more and more open wards for non-COVID cases. So I get the mixtures of 2 samples type. The renovation still ongoing, and hematology also installing the new CD4 analyzer. So many things happen in Sungai Buloh. Okay, next, the last 2 months, actually the cases come down for our inpatients, for COVID cases. And the sample initially, as you can see, for inpatient and outpatient, it's already come down from the March till June, but slowly we are getting the cases up again. Okay, the admissions and also outpatient clinic start to open. And this is the sample that received by unit initially. So I think both for hematology and pathology chemia, the biochemistry lab, less sample because we deployed our sample elsewhere. But slowly we are getting our samples back. The external start to send us back. So I think by the month of August, it's going to start to pick up back to the January and February soon, inshallah. So this is the latest update from MOH website for the clinical stage of COVID-19, and I want to show you the tests that are supposed to be requested lah. Okay, so as you can see, as the disease getting more severe, the pneumonia getting more bad, the test that requested is getting more and more lah. So how about Sungai Buloh? So I try to look back on our patients. So I taken about 30 patient per category. So look back. So somehow one case, the one in red is the number of case per category. So only one patient did send for PCT, although it is not indicated, but so they did send. Okay, but as you can see, the numbers, for example, if you look at PCT, as the disease progress, the PCT also rise. Okay, not solely on the COVID, but it can rise on bacterial infection and also the inflammation. And the similar patterns go for CRP as well. The mean also raised from category 1 to category 5. Similar for ferritin. Okay, the numbers rises. Okay, the dimer none requested among the 30 patient, but it is also raised. Similar for HS/I, so it is raising together with total white cell. But the lymphocyte count remains around 1 to 2 lah. It doesn't raise. Okay. So again, when it times during this time, we also review the practice in the lab. So initially the PCT, I make it open. Now the PCT can only be requested by PACA, by the specialist. The request electronically. So this is one of the way that we revise our ordering system electronically, and this is. Or we only do it after serious discussion with the clinician. So our clinical counterparts also comes in and help us in actually to help us in the laboratory testing what should be done next. So we go through other things also. We do the tube evaluation because the my track need the 5 ml tube. So the track get installed, and the external sample, the clinic kesihatan and other hospitals sending back the sample to us. So we are trying our best to resume back to the pre-COVID era. So again, we get our second unit for BSc coming down from our ID ward. So the blood bank sample will be done in blood bank. The biochemistry and also the hematology will be still done under the BSc in the biochemistry lab. So this is the paper, the initial paper that Tuan Suhaila have shown. So just completed this particular study. We are doing it. We are quantitating the total immunoglobulin for in two platform, the Ethelica and also the Vitros. Okay. So I think that's about it. So thank you everyone.
Thank you very much, Dr. Sharifah Khairul Atika, and also to Dr. Firdaus Masuri, who managed to come in for a very short while. We thought she was not coming, she was not able to make it at all. So thank you for coming in and helping us with this webinar. So now, do we have any questions? No questions, yeah? I didn't see any on the screen. Anybody want to ask any questions? Any of us want to ask any questions? No, I think it's okay. I think we will just end it because we are already running late, right? I'm not sure how many participants are still with us, or have they all decided to pack up and go home. At first we had how many? 40 something, I think, recently. Initially we were supposed to have 180 participants, but I think latest Firdaus was saying it's 40 something. So for now, I think shall we end this webinar and I would like to thank all the speakers, the presenters, Dr. Tuan Suhaila, Dr. Huda, Dr. Atika, and Dr. Firdaus, and also sorry, yeah.
Thank you.
Yeah, and then also thank Roche Diagnostics Malaysia for collaborating with us on this and helping to make this a reality. And also to Firdaus Aziz, who has been working very hard and I think scratching his head why things did not work out. And also, yeah, you all there should take a photo, yeah, for us.
And my MO also sharing her hotspot. She's making this possible today. My MO.
Also to Annie, who is there, she's still there helping you. Yeah, please take a photo for us, yeah, send to us. And then, sorry. So for the participants who would like to receive the certificate, please check the comments, the explanation in the question and answer column. Yeah, you have to log in and somehow get your certificate, attendance certificate printed if you wish. Okay, so I'm like to apologize for all the hiccups we had, and we hope that maybe we can do this again in future. And we also we're going to post this on Facebook, right, Firdaus? Yeah, we're going to put this on Facebook.
Yes. Yeah. Yes.
How do they go? Do they just go to MACB Facebook and just look at it?
Yeah. I will post a video. And they can watch it
Facebook.
there. Yeah.
Okay.
The recorded version will be online after 24 hours.
Okay. So tomorrow only can watch, yeah?
Yeah.
Okay.
You will edit my presentation, right? Because so many stop there.
Yeah, I will try edit as possible.
Okay, thank you everybody.
Thank you everybody. Bye-bye.
Bye.
Bye.
Another one day.